Today we're going to talk about congenital talipes equinovarus and congenital vertical talus. Due to the time limitations, we're going to compare both, try to put some light into the pathology and the pathomechanics and the treatment of both. Talipes equinovarus is a supination subluxation disease of the subtalar joint. It's a rather common disease. It's 1 in 1,000. It's important for you to know that the idiopathic type is the commonest type. Idiopathic means you have talipes in an otherwise normal child, but you have to be vigilant looking for associated neurological syndromes, arthrogryposis. Sometimes it's encountered in hereditary syndromes. The other name for it is clubfoot. As for congenital vertical talus, it's a pronation subluxation disease of the subtalar. Congenital vertical talus is commonly part of syndromes like arthrogryposis, neurological syndromes like spina bifida. It might be idiopathic, and it's sometimes associated with hereditary syndrome, and it's very rare compared to talipes. It's 1 in 10,000 normal. Its incidence is 1 in 10,000. The other names for its congenital rocker bottom foot deformity, we'll see that later. Congenital bisplanus rigidus. Let's see how it goes. This picture here is a picture of an unfortunate child who has both deformities in his feet. The right side, as you see here, is a talipes or clubfoot deformity. The left side is in congenital vertical talus. This is how the feet appears. This is the talipes, this is the congenital vertical talus. The infant is usually referred by the OPG conducting the delivery of the baby. He tells the mother that the foot is deformed. You have to seek orthopedic pediatric consultation. The mother comes to you. My baby's feet is deformed. It's in talipes, it's inverted, it's curved, it's deformed, it's not looking normal. And in congenital vertical talus, the mother tells you the foot arch looks abnormal. It's as if the foot is like a rocker. That is the name, rocker bottom foot. The most striking diagnostic criteria of both diseases are the abnormalities that happen in the talocalcaneal divergence angle. This is the AP X-rays of a child with clubfoot, and this is the AP of a child with congenital vertical talus. I want to today bridge the gap between the biomechanics and the pathomechanics and the biology. We know there is something called the calcaneopedal unit in the foot. The calcaneopedal unit is the calcaneus with everything in the foot except for the talus. The biomechanical principle is that the calcaneopedal unit, the calcaneus with all the foot, moves on the talus. The talus is a fixed bone. All the talus can do is plantar flex and dorsiflex, but the calcaneus can move in 3 planes. And this is exactly what happens in talipes and in congenital vertical talus. If you looked at this picture here, you would notice that the calcaneus, rather than being diverted from the talus, it's internally rotated and its axis is close to match that of the talus. If the calcaneus rotated internally, this is the AP view. If the calcaneus rotated internally, so will all the other components of the foot. That's why when the calcaneus rotates internally to become almost parallel to the talus, everything in the foot moves with the calcaneus on the talus. In congenital vertical talus, it's even clearer here. The talus is sitting in its place. It's not deviated medially or anything. The calcaneus externally rotate, carrying with it the whole of the foot. Everything in the foot moves out with the calcaneus. So this X-ray shows us that the calcaneopedal unit in talipes is internally rotated on the talus, and in this X-ray, the calcaneopedal unit is externally rotated relative to the talus. In congenital vertical talus, if the calcaneopedal unit rotated externally, the talus will lack the support of the calcaneus underneath it, and hence it will drop, it will plantar flex, it will become vertical, and hence the name vertical talus. It's clear in the lateral X-ray. In here, in the lateral X-ray, this is the lateral X-rays of a congenital vertical talus. This is the lateral X-rays of Italipus equinovarus. In the congenital vertical talus, why the talus is completely vertical in here? It's completely vertical because, as we saw in the previous X-ray, the calcaneus externally rotated, so the talus is not supported anymore. What happens? The talus completely plantar flexes. When it completely plantar flexes, because it lacks the support of the calcaneus, the navicular, being part of the calcaneopedal unit, where will it be? What is the relationship between the navicular and the talus? If everything in the foot is moving with the calcaneus, this means that the navicular will become lateral and dorsal to the neck of the talus. Lateral and dorsally dislocated to the neck of the talus. And the child presents to the floor with the head of the talus rather than the calcaneus. Hence the name rocker bottom foot, which means inverted arch of the foot. In talipus, in here, we see that the talar axis is parallel to the calcaneus. How can the calcaneus be parallel to the talus? It can only be parallel to the talus if the calcaneus plantar flexed under the talus. Plantar flexed under the talus. So in the AP view, we saw that the calcaneus in talipus internally rotated with the rest of the foot. In the lateral X-ray, we saw that the calcaneus plantar flexed with the foot relative to the talus. Can the calcaneus plantar flex like in the lateral and internally rotate like in the EP in here without inverting? No, it can't. For the calcaneus to plantar flex and the internal rotate, for the calcaneopedal unit to plantar flex and the internal rotate it had to adduct as well. And the same goes for the congenital vertical talus. In here, the calcaneus externally rotated relative to the talus. And in here, the calcaneus dorsiflexed relative to the talus. You might tell me in here, the calcaneus is not dorsiflexed. It's actually dorsiflexed. Why? When we estimate the position of the calcaneus, we never estimate it relative to the horizontal plane. We estimate the position of the calcaneus relative to the talus. And if you measure the talocalcaneal divergence angle in here, it's increased. This means that the calcaneus has dorsiflexed relative to the talus. This is how the pathoanatomy of the foot in talipus appears. In here, the same as we said before. If you notice, the calcaneus should be divergent from the talus in here, and the whole of the foot should be in front of the talus and the calcaneus in here. This is the normal arrangement. What happened in here? What happened is the calcaneus plantar flexed and internally rotated under the talus, and they carried all the calcaneopedal unit with it. That's why, because the calcaneus internally rotated, so did the cuboid and the navicular. The navicular rotated around the neck of the talus and got very close to the medial malleolus. That's why the part of the superficial deltoid here is very, very contracted. And the head is obscured. You can't see it. You can't approach it from the medial side unless you open this gap. If I asked you what is the relationship between the talus and the navicular, you will tell me the navicular is part of the calcaneopedal unit. If the calcaneus internally rotated, it has to plantar flex to internal rotate. So the navicular will be equally plantar flexed and internal rotated relative to the head of the talus. And this is what gives us the famous cavus part of the name. When the calcaneus internally rotates under the talus, it raises the talus up. It raises the talus up. If it raises the talus up, this is the hind part of the medial longitudinal, hind limb of the medial longitudinal arch of the foot. What happens to the first metatarsal and the navicular? They plantar flex relative to the talus, going with the calcaneus as part of the calcaneopedal unit. What you have when you have the talus dorsiflexed and the first metatarsal plantar flexed as part of the calcaneopedal unit, you have caves. So if we examine the name of congenital talipes equinovarus, congenital, the child is born with it. Talipes, what does it mean? It means if the calcaneus internally rotated enough and the plantar flexed enough and abducted enough, we would actually present to the floor with the lateral aspect of the neck of the talus. This is the talipes. The foot presents to the floor by the talus. Talipes, equino. Why equino? Because the calcaneus plantar flexes. If it plantar flexes, the tendo-Achilles will get slack and it shortens. So the hind foot is in equinus, equino, cavo. Why cavus? Because the talus is raised by the increased support of the calcaneus under it, calcaneus internally rotated and the plantar flexed, pushing the talus up, and the navicular and first metatarsal got plantar flexed with the calcaneus, so the medial longitudinal arch is accentuated. This is the cavus part. Talipes, equino, cavo, varus. Varus is the whole story because calcaneal internal rotation, calcaneal abduction, calcaneal plantar flexion are only part of a composite we call subtalar supination. That's why we called the disease a supination subluxation disease. In here, the reverse happens in congenital vertical talus. The calcaneus rotates out from under the talus, and while it rotates out, can't rotate out alone. It has to dorsiflex, as we said, and it has to abduct for it to be a single composite pronation movement. Once the calcaneus clears the talus completely, the talus collapses as in here and becomes vertical, and the navicular, being part of the calcaneopedal unit, moves with the calcaneus in a dorsal direction, in a lateral direction, and becomes, as the midfoot becomes dislocated in a lateral dorsal manner. I don't want you to find any confusion in the relationship between the talus and the navicular. The navicular is only part of the calcaneopedal unit. It moves with the calcaneus. If the calcaneus moved in external rotation dorsiflexion, so will the navicular. Okay? And the child becomes, his arch becomes inverted. This is why we call it trocar bottom foot, and the child moves on the head of the calcaneus. There are multiple classifications for talipes. The DiMeglio classification is based on assessment of the different deformities. It's scored maximum 4 for each parameter, so it's 16 plus 4 parameters in here. It gives you 20. This is the Pirani score. The Pirani score is well explained everywhere. You assess the medial crease, the curved lateral border, the lateral head of the talus. You assess the posterior crease. You assess the heel if it's empty or full. If it's empty or full, you assess the rigid equinus, and it's a score of score maximum of 6 and the minimum of 0. We owe a lot of credit to this man, the great Dr. Ponseti, who taught us the principle of the Ponseti casting. In Ponseti casting, what do? We first increase the supination of the forefoot Why? Because we have to reduce the midfoot. Remember, we said the navicular is plantar flexed on the head of the talus. So we have to dorsiflex it to reduce the midfoot, like this. And after we reduce the midfoot, we fulcrum on the neck of the talus. We hold the calcaneopedal unit in our hand, and all we do is externally rotated successively till we reach from the internally rotated position to external rotation of the calcaneopedal unit 70 degrees. If you notice, you will notice that we did only one part of the composite, external rotation of the foot unit. As you do this, it's a composite. It happens all together. So the foot is brought out of equinus, as you see. And if you look from the posterior aspect, the foot will also be brought out of varus into the corrected position. It's very important to maintain the correction with the Dennis Brown. The affected foot is held in 70 degrees foot thigh angle, the unaffected foot in 40 degrees. As for congenital vertical talus, we use the DOPS technique, which is the reverse of the Ponseti technique. What do? You fulcrum on the neck of the talus. Remember, you push the neck dorsally and laterally, and then you hold the calcaneopedal unit from the forefoot, and you push it in one direction. It's displaced in external rotation, in congenital vertical talus, in external rotation and dorsiflexion. What do? You push the calcaneopedal unit in plantar flexion and the internal rotation, and this will reduce the midfoot. Once the midfoot is reduced, you do open or close depending of the talonavicular joint, and then after correction of the equinus by tendo-Achilles tenotomy, and that will correct congenital vertical talus. Actually, the Ponseti technique and the reversed Ponseti technique are ideal treatment options for both, and we hardly need surgery ever nowadays. Thank you.